دكتورة رضوى اتفضلي.
Good morning. My name is Radwa Mamdouh, a third-year resident. Today it's my pleasure to address to you the clinical anatomy of the external carotid artery, along with the important skull-base foramen from a neurointerventional point of view. To start with, the external carotid artery originates from the common carotid bifurcation at the level of C3 and C4. It ascends in the carotid triangle and lies anteromedial to the ICA, then crosses laterally near the parotid gland. It terminates by dividing into superficial temporal and maxillary arteries. Its branches in the neck can be divided into 4 groups: anterior, posterior, medial, and terminal. The anterior group includes the superior thyroid artery, lingual, and facial. The superior thyroid supplies obviously the thyroid gland and anastomosis with the contralateral superior thyroid and inferior thyroids, which are our target in thyroid artery embolization in patients of Graves. The lingual artery arises from the C3 level and supplies the tongue, which is important in oropharyngeal tumor embolization. The facial artery, well known for its tortuous course, anastomosis with the ophthalmic artery via the angular artery, which is one of the most dangerous anastomosis of the external and the internal systems. The posterior branches include the occipital artery, which arises from the facial, opposite to the facial artery, and anastomosis with the vertebral and deep cervical arteries. The posterior auricular artery, which is often used as a surgical landmark in parotid and temporal bone surgeries, and both these arteries, and both these arteries, or the posterior branches, serve as collaterals in the vertebrobasilar insufficiency. The medial branch, the ascending pharyngeal, it's a tiny one, but it's very clinically critical. It's a very important feeder in skull-based tumors and dural AV fistulas. The terminal branches, maxillary and superficial terminal, both have rich anastomosis with the ICA, and the superficial temporal is usually used as a bypass artery in the STA-MCA bypass in cases of moya-moya disease. This is a digital subtraction angiogram of the external carotid, showing all its branches. Now let's shift to the principles of the ECA and ICA anastomosis. What are these? These are basically natural arterial connections between both of the internal and the external systems, which provide important collaterals in cases of vascular occlusions and strokes, but also yet creates dangerous connections in targeted embolizations. The ophthalmic artery anastomosis are one of the most feared. It can be reached through the facial artery via the angular artery. The maxillary artery also reaches the ophthalmic branches via the infraorbital artery, and the middle meningeal reaches the recurrent meningeal via the lacrimal branch. What are the clinical importance of embolization? Mainly the applications include epistaxis embolization, juvenile nasopharyngeal angiofibroma, and dural AV fistula treatment. So to sum it all up here in the anastomosis, the facial reaches the ophthalmic via the angular artery, the maxillary reaches the ophthalmic via the infraorbital, the middle meningeal reaches the ophthalmic via the recurrent meningeal. Here is just to point out the important skull-base foraminae. Why are they important? Because they are potential routes for collateral flow between both of the systems, and they are sites of tumor extension, which should be later on embolized. To start with, the foramen ovale contains the mandibular nerve and the accessory meningeal artery, which is a main feeder in most of the meningeal tumors and dural AV fistulas. The foramen spinosum, which contains the middle meningeal artery, and it's also a frequent feeder in meningiomas and dural AV fistulas. The jugular foramen, which contains the 9th, 10th, and 11th cranial nerves, which also is of relevance in glomus jugulare and jugulotympanic tumors, when often embolized, may carry a risk of cranial neuropathy post-embolization. Here's a summary of the most important foramen that we just mentioned. Moving on to the importance of this is the main applications of this anatomy. To start with, in cases of embolization or preoperatively done in cases of meningiomas and juvenile nasofaryngofibromas, our rationale here is to facilitate the surgical resection, and which will be translated into shorter operative time, and thus less risk of infection and reduced intraoperative blood loss. This can be achieved by using super selective catheterization of the feeding branches and using embolic agents as the PBA, onyx, coils, and histoacrylate. The second application is the epistaxis embolization in cases of severe or refractory ones, which are often seen in elderly, hypertensive, and anticoagulated patients, targeting the sphenopalatine artery. And reaching bilateral sphenopalatine arteries is usually done, injecting 150 to 100 to 300 micrometers, microspheres, The complications here include obviously the blindness if it reached the ophthalmic artery. Last application we have is the dural AV fistulas, which are basically connections between the dural arteries and the cortical veins, which can be embolized through usually the transarterial route or the transvenous. And the common feeders here are the middle meningeal, ascending pharyngeal, and occipital artery. And last one is the carotid blowout and palliative embolization in cases of advanced neck cancers or patients who undergo radiation therapy. They can face life-threatening hemorrhages where the embolization is the main modality of treatment through parent vessel occlusion or covered stent grafts in selected patients. If there are unresectable tumors causing frequent hemorrhages, also palliative embolizations comes as a key solution. Here are some examples. So to sum it all up, the major risks of external carotid artery embolization include the ophthalmic artery embolization resulting in blindness, the unintended intracranial embolization resulting in stroke, cranial nerve palsy post-embolization, soft tissue necrosis, allergic or toxic reactions to the contrast, and access site complications, which could all be tackled by following these simple, safe practice points. We start by performing complete diagnostic angiography to map the collateral pathways, use super selective microcatheterization to avoid embolization of the trunk unless absolutely necessary, check for ophthalmic and intracranial supply and never embolize a branch that fills with the ophthalmic artery, choose embolic agent carefully and avoid very tiny particles which are less than 150 microns, inject slowly under fluoroscopy, perform bilateral staged embolization is always better than performing aggressive single session treatments. Stop injection immediately if there is reflux or pain or unexpected tertiary filling. Keep resuscitation equipment and surgical backup ready for massive hemorrhage or carotid blowout. Document informed consent in cases of, which include the most important complications as blindness, stroke, and cranial nerve deficits. And post-procedure monitoring is very important for the delayed cranial nerve deficits. Here are some examples that I would love to show. Here is a case of a meningioma feeded from the middle meningeal artery, pre and post-embolization. The second case is a juvenile nasopharyngeal angiofibroma supplied from the internal maxillary and ascending pharyngeal. Here is a pre and post-embolization of a sphenopalatine artery in case of refractory epistaxis, showing the reduced blush. And lastly is a dural AV fistula, pre and post-embolization, showing the onyx cast, which is supplied from the occipital artery. Thank you.
بنشكر رضوى جدا على التوبيك ده، والحقيقه التوبيك اللي قالته رضوى ده